Hope Rugo, a professor of medicine and director of breast oncology and clinical trials education at the University of California, San Francisco's Comprehensive Cancer Center. We're going to talk about some interesting updates from ASCO 2021. And with me today are my excellent colleagues, very knowledgeable and key opinion leaders in breast cancer, Dr. Jennifer Litton, who's professor of medicine and vice president of clinical research at MD Anderson's Comprehensive Cancer Center, and Dr. Bill Gradishar, who's professor of medicine and chief of hematology oncology at Northwestern University. So now we're going to talk about some other interesting data that was presented at ASCO 2021. And actually, we've been waiting for it for a long time. NSABP B-42 published early data and presented and published it, and then presented updated data with longer follow-up. And we were still waiting to see how genomic tests could better help us decide which patients with hormone receptor positive breast cancer benefit from extending the duration of aromatase inhibitor from 5 to 10 years. And B-42, of course, included a population of patients who switched from tamoxifen to AIs also. They just had to have some AI in the first 5 years, and then they were randomized to complete 10 years of an AI versus 5 years with 5 years of placebo. So we have that data, but we don't know who benefits. And there's obvious implications for continuing AIs after 5 years for our patients who tend to have a lot of side effects that occur every single day with these therapies. So 2 studies were presented. One was looking at the Biotheranostics HI test to see whether or not that could help us predict benefit. Previous data had suggested that potentially it helps to predict benefit if you got 5 years of tamoxifen and then took letrozole or placebo and MA17, and in the trials that looked at extending tamoxifen therapy in node-positive disease after 5 years. The second presentation looked at the 70 gene scoring system to see whether or not your original 70 gene category, high or low, would help to determine the benefit of extending adjuvant endocrine therapy with an AI. Bill, can you tell us a little bit about what these presentations showed and your take on it?
Sure. So with respect to the NSABP B-42, as Hope already outlined, this was a trial that you could either have received an AI for 5 years or a sequence of tamoxifen followed by an AI to 5 years, and then patients were randomized to letrozole or not for additional duration. So extended duration therapy was the question. And the trial demonstrated an improvement in disease-free survival. It never showed an overall survival benefit, but as outlined already, can we tease out among those patients who are those that are most likely to benefit and avoid the toxicity that comes with the therapy in some patients and those who aren't going to benefit. So there have been different molecular assays applied to these data sets to help define, hopefully, who it is that benefits and does not. And one such tool was the Breast Cancer Index. And as listeners know, that's been around for some time. It's been shown to be prognostic over a number of retrospective trials, and even a suggestion that it could be predictive in determining the duration of therapy. But this was an application of that tool to a prospective data set, and they culled out from the B-42 a translational group that was significant that had very similar characteristics to the population as a whole. If you cut to the chase at first blush, the trial is negative, meaning that the application of BCI failed to demonstrate who it was that would benefit from extended durations of therapy. And that's sort of the fundamental takeaway. But if you look under the hood, so to speak, and start looking at perhaps some of the other details, there are some nuances that I think are important. And one of them is that we recognize that many of the higher risk patients tend to recur early if they're going to do so. And if you start looking at the data more when the curves split with respect to disease-free survival at about 4 years, and take the analysis from that point forward, there is some suggestion that you can define a group that perhaps would benefit, and that is the BCI high patients compared to the BCI low patients. But at the end of the day, this analysis, for what the primary endpoint was, did not show that the BCI could be globally applied to this trial and determine who it is that benefits from longer durations of therapy or not. And whether longer follow-up of this data set will offer us more insight, we'll just have to see. But there are some interesting aspects to it. And the second presentation actually was the same trial, but being analyzed with the MammaPrint tool. And again, with the recognition that most of the early recurrences, as I pointed out a moment ago, tend to occur in these higher risk patients, and where you start to see the curves separate overall in the trial is roughly around 4 years. And if you look at it from that standpoint going forward, it does appear that the patients who have a high MammaPrint do not benefit, and there's not necessarily a surprise there. They tend to recur earlier compared to the patients with a lower MammaPrint score, where there may be a hint of benefit. And I think what we have to sort of reconcile with all of this data is it's not an absolute crystal clear picture of how these tools fit in making our decision making. I think these tools can be applied for individual patients where there are questions about the toxicity and whether it is worth continuing. But I'm personally not yet convinced that they actually show us the path forward for all patients.
So it's really interesting, and it's kind of too bad because we have found these tests to be so incredibly powerful in deciding about chemotherapy or not in prognosis. So Jen, how do you decide on which patients should have extended duration endocrine therapy?
It's really hard. The aromatase inhibitors and ovarian plus or minus ovarian suppression, tamoxifen, I think these have just really are some of the biggest mainstays of treating breast cancer and keeping disease away. But they aren't without toxicity. And for many people, they can be really detrimental to quality of life with the hot flashes, vaginal dryness, joint pains. And so as patients are getting close to that 5-year, they're often asking, how much do I want to give up on my quality of life for that? What's that for me? Because risk is so individual. Is it 2% absolute? Is it 3% absolute? Is it? And I'm just not sure that any of these tools, as I've seen this data, helps me get to the question that my patients want to know. For me, I think that the data so far with tamoxifen is very clear. 10 years versus 5 if you can. But right now, unless it's a very low risk, I'm using ovarian suppression and AI for 5 years based on our soft and text data. I don't think the data is really convincing for 10, though I've had some patients beg me for it because they don't want to give it up until the data is matured enough. I think there's still this sweet spot so far around 7 years. And I would love to see some more prospective work with these tools so that we can, I think, really apply them.
Yeah, of course. And one of the issues is that none of these trials looked at the tests prospectively. So that does make a difference because you're always going to have a subset of the total trial population. And this was certainly true with these different studies. But I do think it's an intriguing question about the potential delayed benefit seen with this unplanned analysis of the NSABP B-42 and the HI index, because you expect that the AI you took for 5 years has a carryover effect for 2 to 3 years, and whatever you're doing after that wouldn't kick in for a while. So when they looked at that analysis, they saw the separation of the curves. Now, could also just be invented, but I think it is really pretty interesting data that does, I think, show what we've already seen, which is a carryover effect.
But do you think, the discussion was just well done by Fabrice André, who brought up, I thought, a really intriguing point and nuance to B-42 is that the recurrences were very, very minute number were actual distant recurrences. And in fact, most of these recurrences were, local recurrences or second primaries, which I would see more of an effect on letrozole 7 years, 8 years. At the end of the day, it's the distant that is going to make me want to push this through on someone for 10 years. So I think that that's was a really interesting nuance of this subset of B42. I don't know what you all thought.
Well, the other thing I forgot to mention too is when, Terry was talking about the data, when the BCI was compared to other data sets where it appeared to have some predictive value, the fraction of patients who are getting second breast cancers in B42 accounted for a lot of the events. So again, to your point, Jen, I don't know that we're demonstrating that it's affecting late distant recurrences, but again, the question is, are all these data sets similar, and are the events that are being tracked the same? I think it's still confusing.
So these trials looked at who needs more therapy versus who needs what we think is the standard overall. And I think probably we're still going to be using clinical characteristics largely to direct when we give patients longer duration endocrine therapy, such as having more positive nodes and higher risk disease for better or worse. And I wish that we had good data to know how to prevent those 10-year metastatic recurrences for 1 centimeter hormone receptor positive cancers. And that just seems a tragic area we need to address. But one thing that was interesting, I thought, in that same session was who maybe needs less therapy out of our standard. I don't think we answered it, but the data from the ultra low test from Mammoprint or the 70 gene assay is quite intriguing, where you are way far over to the right. So plus, close to +1. That those patients in a previous study that looked at a retrospective data set by Laura Esserman from UCSF showed that those patients did extremely well, almost regardless of endocrine therapy. What did you think this time it was applied to the MINDACT population? What did you think, Bill?
Well, I think it basically confirmed what Laura had presented in the past, that there is this population that basically has a remarkably good prognosis. And within MINDACT, which, as everyone knows, was a huge trial, there were, about 3,000 patients that fell into the low category. But distinct from that is the ultra low, which is another 1,000 patients. And when you look at the characteristics of those ultra low patients, they predictably tended to be older, lymph node negative, smaller tumors, hormone receptor positive. And most of those patients received either endocrine therapy or no systemic therapy, and only a tiny fraction received chemotherapy. But if you track out how they fared over time, they did remarkably well when you look at the breast cancer endpoints, like breast cancer specific survival. It's in the high 90s. So these are patients who do extremely well, and it really lends itself to this question of whether you can even de-escalate further. Since most of these patients had endocrine therapy, it really raises the issue, do all of them even need endocrine therapy? Might they have actually fared just as well in the absence of that? So I think it really does identify an exceedingly favorable prognosis in a not insignificant fraction of patients.
Yeah, it's a really, really interesting data set. I will say that, the follow-up is not long enough in these patients. So we really need to look at their recurrence risk, especially with that carryover effect at 10 and 15 years. And right now, I don't think that any of us would be comfortable not providing 5 years of endocrine therapy, but we certainly wouldn't give them longer duration therapy. So
I completely agree. I just want to make sure no one, I strongly would encourage people not to start to act on this with ultra low and withhold endocrine therapy. The study doesn't support that. It supports the hypothesis to look at it. So on Monday morning, this doesn't change practice.
Yeah, don't misinterpret my enthusiasm.
Yeah, well, but it's still really interesting. I think it does help us. Maybe those people could get tamoxifen instead of an AI if they don't tolerate the AI, So this was great discussion and really, really interesting data. So thank you very much for your excellent comments and reviews.